We are live.
Good morning, everyone. I welcome you all to the 10th episode of GuruSangam 24-25 edition. Now, GuruSangam was a program that was initiated last year, and through the GuruSangam program, we bring together distinguished teachers or luminaries in their field to lecture on a subject of their choice. Every lecture is detailed and in-depth and is designed to give the postgraduates a very good overview of the subject that is covered. So this Guru Sangam program is a series of over 80 lectures through the next 1 month. And through this Guru Sangam, we hope not only to help the PGs to excel, but to elevate the levels of teaching across the country. With that, I warmly welcome you all, our panelists, our speakers, and also the postgraduates who've joined in this morning. Before we begin our session, I would like to acknowledge and thank all the people who've been a part of the Guru Sangam program and have helped to chart out this program. So foremost is the chairperson of the Guru Sangam program, Dr. Samar Kumar Brasak, who is also the president of the All India Ophthalmic Association. Then our program directors, Dr. Santosh Honavar and Dr. Manoj Mathur, who have very meticulously crafted and given their inputs in designing this program. It is my it's my pleasure and privilege to welcome such a distinguished panel of experts today with us this morning. Today we'll be diving deep into some cataract lectures, and to guide us through this and to give their expert opinions and inputs, we have very distinguished ophthalmologists. We have Dr. Anand Bhandari, who's the director of the Ramaya Memorial Hospital at Bangalore. We have Dr. Mohit Khatri, who's the director of the Mohit Khatri Eye Clinic at Kanpur. Dr. Meeta Joshi, who's a very distinguished ophthalmologist from Indore and who is working at the Rajshri Hospitals at Indore. A very warm welcome to you all. Apart from that, we have Dr. Pranav Ranjan sir, who is a very renowned ophthalmologist and the director and the head of department at the Renu Eye and Maternity Center at Patna. He's a very renowned cataract surgeon and has vast experience in this field, and he's made some very notable contributions to the field. So welcome, sir. Looking forward to your inputs. And the last panelist, that's my absolute pleasure to introduce, Dr. Ragini Parekh. She's the director of the Manorma Netralaya in Mumbai. An expert surgeon and a keen academician, she's renowned for her work in the field of cataract with a remarkable career spanning over 30 years. So a very warm welcome to you, ma'am. And we look forward to the inputs and the comments of all our panelists at the end of the talk.
Thank you, ma'am. Thank you so much for the lovely introduction.
Thank you.
Thank you, Dr. Tinku.
Pleasure, sir. Pleasure to have you all here. And thank you for taking time on a Sunday morning to be with us. Thank you so much. And
good morning.
With that, I move on to our first speaker. So our first speaker is Dr. Sarita Agarwal, who's the professor and head of the Department of Ophthalmology at the Santosh Medical College and Hospital, Ghaziabad. An alumnus from SNMC Agra, she went on to do her post-graduation from the LLRM Medical College, Meerut. She has over 17 years of teaching experience and has authored more than 50 publications in both national and international journals. Additionally, she has delivered numerous lectures at various national and international conferences. She has been also awarded, she got the Distinguished Ophthalmology Professor of India Award by the Forum of Ophthalmology Professors of India. And she's also been given the Research Excellence Award in 2023 by the Institute of Researchers. So with that very vast academic experience, we're looking forward to your talk, Dr. Sarita, and she'll be speaking on anesthesia in ophthalmology.
Thank you, Dr. Bali, for introduction. I'll just sharing the screen.
Yeah. And before we begin, I'd request the audience that has logged in to please keep your questions, your comments, any perspectives coming. So let's make it as interactive as possible. This is a very good opportunity to get all your doubts cleared. We have such a good panel of speakers and, the other panelists. So please keep your questions coming, and looking forward to your talk, Dr. Sarita. Over to you.
Is my screen visible?
Yes, very well.
Good morning, everyone. So today I will be speaking on ocular anesthesia, and that's a very important topic for every subspecialty of ophthalmology. It's not moving. 1 minute, please. Yes. So what is anesthesia? It's a reversible loss of feeling or sensations, especially the loss of pain sensations, and that is induced to perform surgery or other painful procedures. So I'll take anesthesia under 5 chapters. First, I will give the introduction to ocular anesthesia, then what are the various types and techniques, and then the pharmacology of anesthetic agents, complications and management, and lastly, what are the advances and future directions in ocular anesthesia. So moving on to first chapter, that is Introduction to Ocular Anesthesia. First, coming to the history part. So what is done in the ancient practice? The herbal concoctions, that is the mixture of herbs and spices that is diluted in water and boiled, that is used to anesthetize the person. And there was some rudimentary techniques. These were used to anesthetize, and uses of pressure and cold as a primitive method to reduce the sensations. In 1884, Carl Keller used cocaine as local anesthetic, revolutionizing the ocular surgeries by allowing localized numbing. In 1940, there was introduction of lidocaine, and in early 20th century, there is discovery of procaine that provides safer alternative to cocaine. And in mid-20th century, there is development of retro and peripheral block, and that provides effective anesthesia with fewer systemic side effects. And in late facilitate its minimal invasive surgery for cataract and other surgeries. So what is the objective of ocular anesthesia? Definitely it provides akinesia to provide anesthesia and for smooth emergence of the surgery and minimal bleeding and post-operative analgesia. So moving on to anatomy and physiology of the globe, as if you are giving the ocular anesthesia, anatomy, to understand anatomy and physiology part is very crucial. So just watch this diagram. To have the knowledge of orbital anatomy, it is crucial to perform regional anesthesia techniques like retrobulbar and peribulbar techniques. So you can see this is the muscle cone of extraocular muscles that surrounds the globe, and then the optic foramina that forms the apex of the globe. Then this is a matrix of the connective tissue that forms intermuscular septum. Then there are various nerves and blood vessels inside the globe. So, and what are the important landmarks? So whenever you're giving retrobulbar injections, that is given in the intraconal area, space, that is in between optic nerve and the muscles. And this is the extraconal space in which peribulbar injection is given. So retrobulbar injections is given more behind the eyeball. So the knowledge of all these innovations is very, very crucial to understand the ocular anatomy and to give proper and safe anesthesia. So there are 4 recti and 2 oblique eyes that controls the eye movement, and their innovation must be considered to avoid unwanted paralysis and complications. And the primarily, innovation by trigeminal nerve, and to understand these pathways crucial for effective pain management. Then there is ophthalmic artery in the globe. So awareness of the vascular anatomy helps avoid complications such as hematoma formation during the anesthesia, giving anesthesia. So again, the intraocular pressure anesthesia can affect intraocular pressure. That is again a critical consideration during the surgery, especially in glaucoma patients. Then the lacrimal apparatus responsible for tear production, that is also affected by anesthesia, impacting the ocular surface. So the understanding anatomy and physiology of the orbit is must before giving anesthesia. Now, coming to indications of local anesthesia, again, these are surgical and non-surgical. Among the surgical, cataract surgery, all the ocular surgeries like cataract surgery, glaucoma surgeries, extraocular plastic surgeries, and keratoplasty and DCR surgery, local anesthesia is given. While non-surgical anesthesia like diagnostic procedures like conioscopy and ocular ultrasound, therapeutic interventions like intravitreal injections or laser, And sometimes we have to consider the pediatric patients for examination under microscope. Now, the general anesthesia, what are the indications? In what patients you have to give the general anesthesia? Definitely in children and infant, if you are performing any ocular surgeries, in anxious and uncooperative patient, and in mentally retarded patients. Now, coming to chapter 2, that is what are the types and what are the techniques of ocular anesthesia. So these are the various types of ocular anesthesia like topical anesthesia, subconjunctival anesthesia, peribulbar and retrobulbar blocks, and there is subtenon's block, then there is intracameral block, and then there is general anesthesia in ophthalmology. So I'll take one by one. So before giving the ocular anesthesia, you have to prepare the patient. So first educate the patient what you are going to do so that their anxiety is reduced and compliance is increased. And then pre-operative assessment, coagulant or any, you have these drugs at least 4 days before the surgery. Then axial measurement is again very, very important to prevent the further complications. And the most very important part is avoidance of wrong side surgery. So on the day of the surgery, you have to ask 10 times to the patient which eye is to be done. And on the day of surgery, the operative eye is marked. What I usually do, I paste a micropore above the eye, which is to be operated. And while giving the anesthesia, again ask the patient which eye is to be operated. And again, during paint and drape, ask the patient which eye is to be operated. What are the materials that is needed during any anesthesia? In peribulbar, there is a syringe that is 25 mm needle is needed. In retrobulbar, 32 mm needle is needed. And in subtenon, scissors, blunt curved cannula is needed. So coming first on to the topical anesthesia, and what is the mechanism of topical anesthesia? It works by blocking sodium channels in the nerve endings on the ocular conjunctiva. So what are the drugs used in topical anesthesia? Binoxynate, it is used in concentration of 0.0%. It has bactericidal property. Then proparacaine, that is used in 0.5%. It has a rapid onset, short-acting drug, and it is widely used. Then tetracaine, that is used in 0.5%. It is short-acting, least toxic to the corneal epithelium. And lignocaine 4%, that has longer duration of action. And bupivacaine 0.5%, it increases the associated corneal toxicity and it has a longer duration of action. So what are the advantages of topical anesthesia? Definitely immediate visual recovery is there and avoidance of complications that may be happen during the regional blocks. And what are the disadvantages? There is no akinesia, not suitable for the extended surgery, and for topical anesthesia, a well-informed and motivated patient is needed. What are the uses or in what cases you can give topical anesthesia? If there is any manipulations of superficial cornea and conjunctiva is to be done, phacoemulsification or cataract surgeries in cooperative patient, prior to any regional block, then diagnostic procedures like applanation, tonometry, and gonioscopy. If you have to remove small foreign bodies and or during the corneal epithelial debridement. So what are the application techniques? Ensure that the patient is seated comfortably. Instill 1 or 2 drops of anesthetic into the lower fornix. Ask the patient look upwards. Instruct the patient to blink gently to distribute the anesthetic drop evenly across the surface. Now, what are the adverse effects? Definitely, if you overdose the topical anesthesia, there could be epithelial and endothelial toxicity. There could be some patients are allergic to the drugs, and overdose may alter the lacrimation also. So what are the limitations? It may not be adequate for long or more invasive purpose. So coming on to the local anesthesia. So what is the mechanism of action of local anesthesia? When you put local anesthesia onto the eye, it converted into the ionized drug and converted again to the free base. So when it enters the nerve axon membrane, again, it is converted into the ionized drug and it blocks the sodium channels. So what are the anesthesia helping agents? Hyaluronidase, some surgeons use hyaluronidase. It causes more rapid and complete anesthesia than injections. It means it's better to add hyaluronidase. If the surgery is going to take more time, then epinephrine is sometimes used to increase intensity of the anesthesia. It causes minimizing bleeding, but sometimes it may cause retinal ischemia. So its use is usually avoided in patients with underlying cerebral vascular diseases. Sodium carbonate increases the pH of anesthetic solutions and shifting the anesthetic agent bupivacaine to its non-cationic form so that more readily diffuses into the surrounding nerves. So currently, in most of the surgeries, a combination of lidocaine and bupivacaine is reported to be most popular, as the short-acting lidocaine provides immediate anesthesia, while bupivacaine provides longer duration of anesthesia. So first, coming to peribulbar block. Peribulbar block is injected into the extracorneal space, that is a peribulbar space, and from where it spreads to lid and other spaces. And it produces globe and orbicularis akinesia and anesthesia. Usually the lignocaine 2% and bupivacaine 0.5% is used, along with hyaluronidase and adrenaline. So 6 to 8 ml volume is usually needed, along with 25 gauge needle and 2.5 centimeter long. So as the patient, whenever you are giving peribulbar anesthesia, the patient has to be in the supine position and in the primary gaze. So first give along the lower lid, that is the junction of medial 2/3 and lateral 1/3, and parallel, it should be the parallel to the orbital layer. And second injection is to be given on the upper side, that is just inferomedial to the supraorbital notch, or just medial to the medial canthus. So what is the exact technique, how you have to do the bulbar injections? So needle inserted transcutaneously at the junction of medial 2/3 and lateral lower lid, adjacent and parallel to the orbital 4 for about 2.5 centimeter. Gentle aspiration is done first to see whether any vessel is punctured, and then approximately 5 ml LA is injected. Then pressure is applied for a few minutes. Then second injection is given just medial to the medial canthus or inferomedial to supraorbital notch. Again, pressure is applied for few minutes. And then sometimes Honan pressure cuff is applied for 15 minutes. So what are the advantages of peribulbar block? It is given in extracorneal anesthesia, and this is causes less injury to the optic nerve and globe, but pain, conjunctival chemosis, and there is less kinesia than retrobulbar anesthesia. There is a short video of peribulbar block.
Directed at a 90-degree angle to the frontal plane of the orbit, parallel to the visual axis. Then the needle is advanced posteriorly approximately 0.5 inches or 12.
So how it is given in the extracorneal spaces? Now, coming to the retrobulbar anesthesia. So retrobulbar anesthesia is given in the intracorneal muscle. So you have to go very posteriorly. And it blocks ciliary nerves and ganglions, 3rd, 4th, and 6th cranial nerve. And it provides better akinesia and anesthesia to the globe. Again, the position should be supine and in the primary gaze. And the site of injection, that is given again in the lower lid margin, just above the point between medial 2/3 and lateral 1/3 of the lower orbital margin. So a 22 gauge is usually taken, that is 3 to 5 centimeters long, that is entered transcutaneously at the junction of medial 2/3 and lateral 1/3 of the lower orbital margin, and needle is inserted directly backward for 15 mm. And angle is upward and medially towards the apex of the orbit, because retrobulbar anesthesia is given in the intracorneal space. And then pierces the intramuscular septum, and aspiration again, and injection is given of around 2 to 4 ml. So after the injection, again, the intermittent firm digital pressure, that is a must for 20 to 30 seconds. And then 5 minutes duration to prevent occlusion of the retinal circulation. And it provides hypotonia and diffusion to the anesthetic agent. And sometimes we may use suprapunctal or Henon balloon for 10 minutes. So again, I'll just wanted to show you a small video of retrobulbar anesthesia so you can see in which space it is going. So see, the needle is going in the intramuscular septum, and the anesthesia is given in the intracorneal spaces. So you can see the optic nerve that is very close to the intramuscular septum. So the excess of anesthesia is usually avoided to avoid the optic nerve damage. So successful retrobulbar block is accompanied by anesthesia, akinesia, and abolishment of oculocephalic reflex. 2 to 5 ml is usually given. And what are the advantages? Complete akinesia is received. This is adequate and quicker anesthesia, and minimal amount of agent is required. But complications are really more with the this retrobulbar injections like hemorrhages, globe perforation, optic nerve sheath injury, optic nerve trophy, and so on. I'll take in the chapter of complications and management. And what are the contraindications in which you must avoid retrobulbar injections? Definitely, if the patient has the bleeding disorders, so and or there is a history of open eye injury, extreme myopia patients should avoid retrobulbar injections, and in posterior staphyloma. Now coming to subtenon block, that is very much nowadays in the practice. So first of all, again, topical anesthesia is given. A small incision of conjunctiva 2 to 3 mm is given halfway between inferior limbus and fornix to open into the posterior subtenon space. Blunt cannula or needle is inserted to subtenon space, and 3, 4 to 5 ml of anesthesia is introduced. So again, the short video I just wanted to show you. So this needle is going into subtenon space, and usually 3 to 5 ml of anesthesia is introduced. And really, it is very useful if the patient is high myopic. So in high myopic, usually the regional block should be avoided and subtenon or the topical block should be preferred. Now, what are the advantages? Again, it avoids vascular and optic nerve injuries. It requires lower volume of anesthesia. It is better anesthesia to iris and anterior segment. But the disadvantages of subtenon, most of the time it causes subconjunctival hemorrhage and the more post-operative morbidity. Now, coming to intracameral anesthesia, again, the agents are used are lidocaine 1% and bupivacaine 0.5%. And it is usually combined with topical anesthetic agent, and that's an effective and safe method to achieve analgesia for cataract surgery. Subconjunctival anesthesia, it can be utilized in almost every operations on eyeball, even after the cataract surgery. Some surgeon used to give antibiotic and steroid through subconjunctival route. And so needle is introduced subconjunctivally, and the anesthetic solution is injected behind the bulbar conjunctiva at various distance from the limbus. Now the frontal blocks, although the frontal blocks are not used nowadays, but it is some surgeon prefer in ptosis surgery. And what is the site of surgery in frontal block? That is just below the midpoint of supraorbital margin, transcutaneously directed towards the roof of orbit. And 2 ml of anesthesia is given. Now, there are some facial blocks that we use usually in the early days when some surgeon prefer ECC, or if the surgery is taking a lot of time. So there are various types of facial blocks. So I think the student should know at least what are the various facial blocks. So these are Von Lentz. Then there is O'Brien injections. Then there is Nutbent. And then Atkinson block. So I'll take just a short description of these. So in classic Von Lentz techniques, 1 centimeter behind the lateral margin of orbit is given, and 1 to 2 ml is injected at the inferotemporal rim, and then redirected supranasally. And only the terminal branches of facial nerve is blocked through this. Then there is a facial nerve block that is given 1 centimeter anterior to the tragus of the ear. Then there is a Atkinson's block that is introduced to overcome the disadvantages if Von Lentz O'Brien's block are not so effective. Then the Nutbents and Lehmann technique that is given at the main trunk of the nerve. So coming to the chapter 3, that is the pharmacology of the anesthetic agent, and that is very, very important to use. So the onset means proparacaine and tetracaine, as I discussed before, they are rapid onset and shorter duration. And these are metabolized in the liver, ester type. They are hydrolyzed by plasmaesterases. And then the side effects, the local anesthetize causes corneal toxicity, then allergic reactions, and some also causes systemic toxicity. Then what are the prevention strategies so as you can prevent the complications that is happening due to anesthesia? So you should adhere to the recommended doses. Proper technique should be employed while giving the anesthesia. Continuous monitoring of the patient should be done, and early detection and intervention for any adverse effect if it happened, and inform the patients about the potential side effects. So sometimes there is drug interaction also, so you should know about these also. So if the patient is taking anticoagulant, that is, there is an increased bleeding risk, so it should be discontinued at least 3-4 days before the surgery. Or if the patient is taking CNS depressant, then only it should be discontinued. And some herbal supplements also can also affect the coagulation. And age consideration should be chosen if you have to require the dose adjustments. And certain anesthetic agents may pose risk to the fetus or nursing infant. So careful selection of the drug is needed. So the most important part or most important chapter of the topic is complications and how do you manage it. So sometimes there are minor complications. These are very, very common, like conjunctival edema. Then there is subconjunctival hemorrhage and bleeding into the eye that causes ecchymosis. Now, the major site and life-threatening complications, and one of the serious complication is retrobulbar orbital hemorrhage. And one should know, means one should know the sign if it appears and how to it managed immediately. So the cause is accidental puncture of the blood vessel during the injection. Retro means behind, bulbar means behind the globe. So bleeding occurs behind the globe. It should be venous or arterial. So what happens in venous retrobulbar hemorrhage? It is due to the perforation of vein. It is slow in onset. There is blood stain chemosis. Sometimes it looks like this picture. And there is very high intraocular pressure and there is increasing proptosis due to the blood collection behind the globe. So how will you treat this? Again, you have to reduce the pressure by giving intermittent digital pressure, then reduction of IOP by giving mannitol and Diamox, and immediate postponement of the surgery should be done. Arterial RBH, because the pressure is very much high in the arteries, so whenever the arteries are perforated, it occurs quickly. The pressure is very, very high and it is really difficult to manage. So firm digital pressure and control IOP is a must. And if it is not controlled by the medical treatment, canthotomy or cantholysis or orbital decompression should be done. So what are the risk factors, or in what patients the chances of RBH is more? If the patient is having pre-existing vascular or hemorrhagic disease, if the patient is on anticoagulant, or if large bore needle is used like 22 or 23 gauge needle, or if long needles are used more than 31 to 38 millimeters needle. So always use fine gauze needles. The approach should be lateral inferotemporal because that is the least vascular site. Avoid deep needle placement. And pressure to eye after every injection, there should be the pressure of eye at least 1 minute after the injection. Second most serious complication is globe perforation. So what happens whenever there is a globe perforation, there will be soft eye, and myopic patients are more prone to the patient. There is marked pain in the patient, there is hypotony, and there is reduced red reflex due to the vitreous hemorrhage. So what are the risk factors? In which patients it is more common? Like myopic patients, and if the patient has axial length more than 26 millimeters, if there is posterior staphyloma, if there is endophthalmos, if you have given repeated injections or extra quantity of the injection, and bevel of the needle, always remember, bevel of the needle should be turned away from the globe. Or in uncooperated patient, the chances of perforation is more. So how do you manage? If once perforation occurs, how do you manage? Important, always cessation of the or cancellation of the elective surgery, and patient should be referred immediately to the retinal surgeon. And third dreaded complication is a nerve injury. So optic nerve may be damaged by direct trauma by the needle, or there is ischemic damage from the intrasheath injections or the hemorrhage, or if there is retrobulbar hemorrhage that compresses the optic nerve, or excessively applied external pressure can also cause nerve injury. So what are the risk factors? Again, the small orbits, placement of long needles. So always use needle that is less than 31 millimeters. And the very important or very serious or dreaded complications is the oculocardiac reflex or the trigeminovagal reflex. So what happens in this? There is bradycardia and hypotension due to mechanical stimulation of the globe, and it is commonly seen during general anesthesia, especially common in the children, and it is more common during the squint surgery. So what happens when there is a muscle stimulation or when you touch the muscle? So what is the pathway? The ciliary nerves are especially near to the muscle. They get stimulated. It goes to the ciliary ganglion. Then it relays to the ophthalmic branch of the trigeminal nerve. It relays to the brain. And from brain, the efferent pathway is started. And via the vagus, it goes to the heart. And vagus nerve, that is a parasympathetic nerve that causes bradycardia, means reduced respiratory rate and reduced BP. So what is the treatment? Stop the surgical stimulus immediately, give immediately atropine. So ensure adequate ventilation. So ocular cardiac reflex is very, very important. That is a very serious condition. Next is a brainstem anesthesia. That is due to the spread of local anesthesia along the optic nerve sheath. And sometimes the patient complain of drowsiness, loss of verbal contact, cranial nerve palsies, cardiac arrest. So immediately stop the anesthesia. Then the next complication, dreaded complication, is muscle palsy. If you hit muscle, extraocular muscle, because these are inside the globe, that is why anatomy and physiology is must to understand. Sometimes there is diplopia and ptosis, especially if you have injected the large amount of the anesthesia. Now, last chapter of my presentation, that is advances and future direction. So ultrasound guided ophthalmic regional anesthesia, recent researches highlighted that needle tip location without ultrasound emphasizes the significance of imaging local anesthetic dispersal. And ultrasound biomicroscopy, power Doppler, and ultra-fast B-probe with integrated 3D scanning are coming up as a potential tools for improving ophthalmic anesthesias by ultrasonography. Then optical coherence tomography, potential applications in visualizing ocular structures during the anesthesia to guide procedures and assess anesthetic effects. Then robotic and automated systems, the development of robotic system for precise delivery of anesthetic, particularly in delicate ophthalmic surgeries, and automation in monitoring and adjusting anesthetic pain, enhancing safety and efficacy. So this is the end of my talk and just my few of the points for take-home message. Knowledge of anatomy and physiology to avoid the complication is must. And always remember the local anesthetic agents are myotoxic. Direct injection into the muscle should be avoided. The eye should be in the primary gaze. See, I'll just tell you why the eye should be in the primary gaze. So what happens in the primary gaze, optic nerve is slightly medially. So when the patient moves his eye in the needle path, optic nerve might come there, then that might blocked or damaged. So always give injections in the primary gaze and bevel end of the needle should be facing the globe. So summary, you should know the various techniques and the choice of the technique depends on individualized based on the specific needs of the patient. These are my references. Thank you for your patient listening.
Thank you, Dr. Sarita Agarwal. That was an excellent overview of the anesthetic techniques in ophthalmic surgery. And I'm sure it's going to be very useful for the PGs, not only, for their theory paper, but also for their practical day-to-day surgeries. So with that, I throw open this talk to the panelists for their expert comments. So I first invite Dr. Pranav Ranjan, sir, for your comments. Anything that you'd like to add to this?
Yeah, very nicely presented and elaborate presentation, especially for the postgraduates, and not only for the postgraduates, but for everyone. One thing I would just like to add, when you are using a topical anesthesia, especially for cataract surgery, anesthesia should not be before 15 minutes. You should start it just 15 minutes prior to the surgery time, and every 2 to 3 minutes initially, and then just before the surgery, because proparacaine is epitheliotoxic. It also changes the ocular surface, the tear film also. So during the time of surgery, the visualization can become difficult, and because of the softening of the epithelium, that can also impair the visualization during surgery. So that is, do not 5 minutes before surgery. It should be started approximately 15 minutes before surgery. And secondly, when you're using either a retrobulbar or a peribulbar injection, what I normally do is when I put it in the inferior place, like the medial 1/3 and the lateral 1/3 and the medial 2/3, that point, I direct the injection towards the floor of the orbit, so that once I hit the floor, just smile, I just withdraw and then go towards the apex. So that primarily reduces the chance of perforation, either for both the perivalvular and the retrovalvular. These are the 2 points I would like to add.
Thank you, sir. Excellent.
And of course, the bevel should always.
Exactly.
Dr. Ragini, ma'am, anything that you'd like to add to this? Okay, so Dr. Mohit, would you like to give some comments or any inputs?
Hi, ma'am. It was a great presentation. And one thing I think that should be added here is that all the refractive surgery we are doing in a topical. So, to add to the list what was shown, the refractive surgery element can be added. That most of the refractive surgeries are done under topical. For cataract surgery, in my personal experience, I have seen for last 3 to 6 months I've been practicing that if we add intracameral, maybe a self-preserved lignocaine or something like phenocaine that's readily available, that gives better analgesia to the patient. So even if you catch hold of the iris sometimes during phaco or some irrigation aspiration port, then also the patient never winces. Earlier I was just putting proparacaine drops, but once I have started giving just a zero point 0.1 ml or maybe lesser 0.05 ml of the drug intracameral, then my life is easier for small pupil surgery. For those in which advertent floppy iris is there and I catch iris, then the patients are comfortable. And we must be taking decision at the very right time. If the patient is uncooperative and the surgery is being stretched under topical, it becomes a very bad experience for the patient as well as the surgeon. So timely, the plan B should be resorted, and we should, have access to Subtenon or anything else which we want. I think Subtenon is the safest in between the procedures. So rather than having our ego tall and stretching under topical, we should give a Subtenon reinforcement and go through the surgery smoothly. Rest was just brilliant.
Thank you. Dr. Ragini, ma'am?
Yeah, sorry, I was muted at the time. It was a wonderful presentation, very, very comprehensive and important for all. I would just like to mention one thing. Madam has very clearly said that, we must mark the eye and, confirm with the patient. So marking the eye is extremely important. And when we do high volume surgery in medical colleges, and you should know the patient. So we started this system of labels where we label the eye also. And I would like to point out, that there are certain instances where the patient changes the marking. So if it's a sticker or something, a pen would be better, because the patient, one patient had a macular scar in one eye and the cataract in the other eye, but the patient wanted the eye with the macular scar surgery. So one has to be very, very careful that the patient should not be able to change the stickers or the label. So marking has to be you have to be very diligent in marking so that the patient cannot change. So we changed over to pens, later on. So, but marking is extremely important, which is also an important thing that ma'am mentioned. And it was a wonderful presentation. Thank you so much, Sarita ma'am.
Thank you.
Thank you, Tinku ma'am.
Dr. Bhandari, sir?
Yes, fantastic presentation and small things. The marking, as Ragini ma'am said, has to be in a marker. Stickers, some fidgety patients can remove it. And in the end of the high volume surgery, the patients get irritated. They keep rubbing their face and all these things in a camp setup in a medical college like us. So marking has to be done by the marker and by a doctor. This is very, very important medical legal aspect. Lot of times the sisters in the ward do the marking. We have come to a strict conclusion that a postgraduate or a fellow or a doctor present there will mark the site. This is very, very important for medical legal aspect. And in general anesthesia, we have to look for this bucking. Patient with the mild anesthesia, general, they say not deep, superficial anesthesia. You have to talk to the patient, the anesthetist, the newer ones who are rotated, tell them that we don't need bucking. And as soon as in between your main step, if there is a bucking, you'll catch hold of things which are not required to be caught in your phaco. And the other one is people, the camp patients sometimes or other patients feel very comfortable in sleep. So you should make sure that they don't go into deep sleep and suddenly you all would have experienced this. So these two things are very important in general anesthesia, and marking has to be done by a doctor. And there is, because it's a medical college, we have a call out is a must for a site call out, and IOL call out is a must before every patient. This has become to a rule because all surgical branches in our medical college do a call out. We also do a call out with the expiry date of IOL and the IOL power for the patient. Otherwise, a fantastic presentation, good for PGs as well as us.
Thank you, sir. Dr. Meeta Joshi, ma'am, looking forward to your comments.
Wonderful presentation, and it's great to hear all the tips which are being shared by the panelists. I think that call out is a very good idea, sir. It should be followed everywhere, right? And just one thing, like sir said about the patient going off to sleep, I have seen even in topical anesthesia, patient goes off to sleep. So the moment they are lying down, they just go off to sleep. So it is important to keep talking to the patient in between so that at least they are awake and oriented to their surroundings.
Thank you. So my question to the panelists, like the subtenons anesthesia is now becoming popular, and especially in a few countries like UK, I know they use it a lot. So do any of the panelists, is it your preferred technique, the subtenons block? Dr. Mohit, you mentioned that you do give subtenons. So could you just elaborate on the technique?
I just augment it sometimes when the things are tough or they are prolonged. Suppose if there is a PCR or if I am doing a secondary IOL and it wasn't planned electively, then only I resort to subtenons. And for that, definitely, as ma'am has told, that same technique works. I just snip off some conjunctiva and the tenons in the maybe inferolateral fornis area, and with the visco cannula, new visco cannula is the one which I resort to, and then I use lignocaine to maybe 2 cc's enough or maybe lesser. So that helps me to tide over the situation. But I don't give subtenon as the primary anesthesia for the procedures.
Another question that we have in the chat box is what are the precautions that we should take in a patient with a large axial lens, that is a high myo, to avoid growth perforation? Dr. Sarana?
For phaco surgery, I think we can go for topical if the patient is in good rapport. You just can observe how good he was with the biometry or maybe applanation tonometry, and if the patient was cooperative and looks educated, I think topical is the best way to go for intraocular surgery, not detachments, but rest others can be managed under topical. If still something goes wrong, then yes, subtenon augmentation should be the choice. Peribulbar the last choice.
Any other panelists would like to add something? Any any?
So, Tinku ma'am, even when we were in a medical college with the setup where patients were very poor, it was the rule and the norm that high myopes should be operated only by Phaco and not SICS, because they have staphylomas and you don't know how the eyeball will grow in staphylomas, and the possibility of puncturing the eyeball is extremely high. The second thing is that when you're doing SICS, there is hypotony and there could be tears with retinal detachment. You are a vitreoretinal surgeon, so you would know more about it. So, preferable technique is phacoemulsification with topical anesthesia. Now, this concept of augmentin with subtenons is very, very good. The problem in patients is that now with patients with premium IOLs and under topical anesthesia have high expectation. So any sort of subconjunctival hemorrhage is something that is frowned upon, and patients always feel ki hamara aankh laal ho gaya and all that. We are doing lots of people under topical anesthesia, and so they are cooperative. I really appreciate Dr. Pranav Ranjan sir's point about the time of anesthesia with paracaine, because once the cornea becomes dry and toxic, fine aspiration of cortex or visibility, and the patient complains of post-operative pain because of the corneal dryness. So that is also very, very important. And one thing I would like to say about the call out, we innovated the system of labels where the patient's name is written, because you have a lot of Lakshmis in India, Saraswati, same name. So with the surnames, with the I, with their IDs, with their diseases like hypertension, which surgeon is going to operate, and the back of the card, the IOL number, the IOL power, the type of IOL, everything. So it is like an ID of the patient where the chances of making mistakes are fewer. Of course, there are many tiers where double check is done, like the primary resident who's dilating, the person who's giving the block, the assistant on the table. There are multiple operation lists. So in our case, where we have two eyes, such mistakes can be avoided.
Thank you, ma'am. Excellent pointers. So
one thing I just like
Yes,
to add to it. So you can use an intracameral also for myopic patients if they are uncomfortable.
Yes,
Apart
sir.
from the topic,
Yes,
between
sir.
the surgery.
Thank you.
I have one point to ask the panelists and the experts. Often we are doing subsequently many phacoemulsification one by one in an OT, and then often we ask somebody to add upon a drop of paracaine. If the patient is moving the eye, एक drop और डाल देना. So that eye drop is in the OT, and one of the floor assistant is having that eye drop and puts it there. So should it be in a more controlled fashion? Is there any experience on sterilizing the drops, or where should it be kept so that in between the procedure, if the eye is open, suppose the ports are already made or the incisions are made and you are doing phacoemulsification, you started making rexes and somebody says she's moving the eye, just put a drop of paracaine. So how safe is it, or somebody has had any problem regarding that?
No, I've got a lot of experience about that. I have been using it. I use a new vial in the OT that is separate from the OPD vial. A new vial is open.
Yeah.
And what precaution I take is that I put in an air or a viscoelastic inside the entire chamber so that there is no ingress of the proparacaine from the surface of the cornea. This is the precaution that I take. And
great.
after that, just wash it after a few seconds and then proceed with the surgery.
So I think this should be kept in mind that there should not be any ingress of the drop instilled on the surface into the eye.
There is an important point, sir, beautifully said about the visco and filling it. One more thing is, before we start surgery, when you are putting the speculum and when you are giving a wash to the eye after the betadine, the blink reflex is not abolished. So before starting the procedure to augment the drop is the right time to do it. So that is, so to wait patiently and to wait for the patient to become comfortable, asking the patient to open the other eye too. And the third thing is that I think what we do is we use intracameral after that, because like you said, Dr. Mohit sir, you've brought up a very pertinent point about things going inside the eye when the eye is open. These are micro things which are not paid attention to and which may be major causes of infections.
Correct.
Thank you.
Very, very important.
I would like to add one more thing. What you can do at this time is diluted xylocaine can be added by the assistant. So it is on your table, on your OT trolley, and has been from a sterile vial, so that you don't need to add paracaine from outside.
Yeah. Yeah, excellent point. Thank you, Dr. Meeta. So thanks for the excellent discussion. And with that, we move on to our second talk for the morning. I'll just share my screen. So this talk will be by Dr. Virendra Kumar Pal. And to give you an introduction to Dr. Virendra, he's a professor at the Prasad Institute of Medical Sciences at Banthara, Lucknow. An alumnus of the King George's Medical College, Lucknow. He went on to do a fellowship at the Arvind Eye Hospital, Madurai. He was previously working as a professor at the Varun Arjun Medical College and Rohilkhand Hospital in Shahjahanpur. He's also been an ex-professor and deputy director at the Regional Institute of Ophthalmology at the Sitapur Eye Hospital. He has a vast experience. He's been an ophthalmology teacher for the past 18 years. He has trained a lot of Phaco trainees and also SICS. He's been an SICS trainer also. He's been a speaker, moderator, and organizer of various conferences. And he was awarded by the ACYN for the prevention of blindness. And today, Dr. Virendra Kumar Pal will be speaking to us on the basics of phacoemulsification. Again, a very, very important topic for everyone. So looking forward to your talk, Dr. Pal, and I request you to share your screen.
Okay, thank you everybody and experts. Just I am sharing my slides. Okay, my slides are sharing.
No, they're not visible, Dr. Pal, they're not visible. Yes.
Now they are visible and I am audible. Okay, thank you.
You can make it full screen, please.
Okay, yes. So thank you everybody. My topic is basics of Phaco, tips and tricks for the beginners. As we all know that phacoemulsification.
Doctor, can you please make it full screen, PowerPoint show mode, please?
Yes, now it is visible.
No, sir. Bottom right, next to 100%, there is the icon, right? Just click on that. Bottom, absolute bottom taskbar में नीचे सबसे.
Okay, right. Now it's okay.
Yeah, perfect, doctor. You can please continue.
Okay.
Thank you.
So my topic of presentation is basics of Phaco, tips and tricks for the beginners. As we all know that phacoemulsification is the gold standard surgery of modern day for the cataract exception. So everybody wants to be learn Phaco and want to become a very good surgeon for Phaco. So it's for the beginners. And as we all know that mental preparation is required before you go for the physical preparation, because you must believe on yourself before you go for the Phaco, and because the prerequisites for shift to the Phaco from surgeon who are doing SICS or ECC with good experience with the ECC, because ECC teaches the behavior of the posterior capsule, and small incision cataract surgery have certain common points like tunnel formation, capsulorhexis, and hydro procedures, and expertise to use both hands and one foot simultaneously, and rehearse all the procedures in your mind before you go for the Phaco surgery. Then, because it is a machine-based surgery, so must understand about the machine. First one is console. It is a brain and display of the machine, and handpiece. It is output device, and foot pedal. It is input device. The first part, that is console. The console consists of computer which controls all the functions of the machine. The settings for the various parameters, that is power, vacuum, and flow rate, are fed in here, and these settings represent the maximum level of the parameter that will be achievable. It is not actual one, but it is a achievable parameters. Then handpiece, there are two types of handpiece. One is Phaco handpiece. The Phaco handpiece contains the piezoelectric crystal. When it vibrates with electrical power, it converts energy into ultrasound energy. And handpiece have a handpiece with titanium tip and silicon tube with two infusion ports. And next one is irrigation aspiration handpiece. It is two types. One is coaxial, in which both aspiration and aspiration are present in one tube, and bimanual, where they are separate. Then come to the foot pedal. It is a input device of the Phaco machine. It has a central part and side keys as shown in the picture. The foot pedal have two dentation. that is D1 and D2 lines are there. And with these two dentations, it is divided into three excursions. First excursion is irrigation. Second is irrigation and aspiration. And third one is irrigation, aspiration, and power. That means if you use the power, that means your irrigation and aspiration is already working. And if you are using aspiration, that means your irrigation is already working. And resistance is felt at the dentations or positions, and there may be tactile feedback and auditory feedback is also present. Then foot gradient is the expression of foot pedal in millimeter to produce unit power of the phaco energy. For example, if total exertion is 10 centimeter, that is 10 millimeter, at preset 100% power, foot gradient is 100 upon 100, means one power increase with each millimeter of the depression of the foot pedal. Similarly, if preset power is 50%, that means foot gradient is 2 millimeter depression of foot pedal, increase the 1% of the power. It means that if the preset value is lower, that means you have better control on the foot pedal. Then side keys, there are two side keys. One is reflex one and another one is continuous infusion mode. Reflex one on kicking invert the flow of respiration. So it split the things. Suppose iris is just anchored in the port, then you use the reflex key. Second one is continuous infusion mode. If press these keys, infusion remains continuous irrespective of the position of the paddle. Then PhacoDynamics, the various functions of the Phaco machine and their interrelationship is called PhacoDynamics. Ultrasonic power is used for the phacoemulsification and irrigation aspiration for safe suction of the emulsified material. Irrigation aspiration system and the parameter on which it depends together are known as fluidics. Then power is generated by the vibration of piezoelectric crystals. Usually 2 to 6 piezoelectric crystals are present in various types of machines, and as more as the crystals are there, the stroke length is more, or more power is there. Stroke length is the length of to and fro movement of the phaco tip, and frequency is the number of stroke per second. That is a variable from 29 to 60 hertz. So power increase with increase in the stroke length and frequency. That means better cutting. Then mechanism of the phacoemulsification. There are some mechanisms of phacoemulsification, that is the jackhammer effect. It is bombarding effect of the phaco tip. And second one is the cavitation during inward excursion of the phaco tip. Tip move faster than water, so a cavity creates, and due to faster movement of the fluid in space creates an implosion. And simultaneously, acoustic waves are also working, and they break the tissue. Then phaco tips, the angulation of tips may vary. The angulation of phaco tips may vary from 0 to 60 degree. More angulation is directly proportional to cutting power, but inversely proportional to the holding capacity. That means if the angulation is more, that means cutting is more, but their occlusion is their holding power is lesser. So for the beginners, it is better to use a tip which is balanced between cutting power and the holding capacity, like 30 or 45 degree phaco tips. What? My slide is not phaco tips. Then other type of phaco tips are microflow tip is useful in soft cataract, especially those less than grade 3. Kelman type tip has a downward angulation. This is ideal for sculpting in hard cataract and eyes with deep AC. And cobra tip, the cobra tip has the base of microflow tip probably and that of the regular tip distally. Then control and delivery of the power. All machine provide 0 to 100% power, and the power required can be infusion from the computer-controlled panels. The exertion of foot pedal in Phaco mode will determine the amount of power being delivered. P0 is minimum and P max is 100%. Then come to the modes. There are two types of mode. One is linear mode and panel mode. Linear mode is further divided into continuous one. Phaco start at P0 and amount of Phaco delivery reaches its preset maximum at maximum exertion of the pedal as shown in the figure 1. These pulse mode, each pulse of energy is followed by a gap of equal duration as shown in the figure 2. And hyperpulse mode in newer machines has softwares which can have pulses in hundreds and thousands as shown in figure 3. And second one is panel mode. Here reaches maximum as Phaco started. That means if pedal is pressed, then delivery of the power is maximum. Like burst mode, where maximum power is delivered delivered at intervals which vary with the amount of you depress the foot pedal. That means frequency is increased when you press the pedal mode. Then duty cycle is the duration of on and off time as shown in this figure. One on time and one off time. Then fluidics, the fluidics of machine refers to the integrated functions performed by the infusion and aspiration system by which a stable AC is maintained. And irrigation, the infusion system consists of a bottle, the height of which provides the gradient for flow. The tubing from the bottle is run through a pinch valve, which is controlled by the foot pedal. The infusion is gravity fed, nearly at 2 feet bottle height. It is nearly 45 millimeter of mercury, and at 3 feet weight, it is nearly sufficient for entering the eyes. Sufficient fluid entering the eye. Raising the bottle height too much can have undesirable effect due to the fact that AC has a fixed balloon and trying to fill excess fluid result in general stress leading to patient's discomfort. So optimum height of the bottle is required during the surgery. Aspiration to certain functions like lavage, this function of flow rate, and hold by creating a vacuum and maintain a cool environment. Then there are two types of pump. One is peristaltic pump, which is flow-based. The rotation of the rollers by the pump pinches the soft silicone tube, creating negative pressure by squeezing the fluid out of the tube. And another type of pump is the Venturi pump. The shift movement of a compressed gas creates a negative suction forces, vacuum inside a closed chamber. In a Venturi system, this principle is used to create a vacuum in the cassette or a closed chamber. This vacuum is then directly transmitted to the handpiece. The amount and this vacuum and of gas decided the level of vacuum developed in the cassette. This process controlled by the foot pedal. So important differences between peristaltic and Venturi system is peristaltic is flow-based, Venturi is vacuum-based. Suction pressure created by peristaltic pump is rotation of the rollers by the pump, pinches the soft silicone tubing. In Venturi, there is shift movement of a compressed gas. Rise time in peristaltic is slow. Start vacuum yields are faster but not absolutely linear. In Venturi system, fast, linear, and dependent upon the highest preset vacuum. Then flow rate is a removal of fluid in a unit of time. The higher the flow rate, the lesser the rise time, and the sooner the debris in the AC is clear. Optimum flow rate is 20 to 36 cc per minute. Then vacuum measures the strength of the hold. The holding power is inversely proportional to the pore size and the angulation of the tip and proportional to the vacuum. The rise time is the time taken by a machine to reach maximum preset vacuum after occlusion has been achieved. Then come to the surgical part, which is first important thing is central safe zone. This is an area within the capsular axis margin, which is bounded vertically by the cornea on the top and the posterior capsule in the opposite direction. This is the area with maximum space in the AC. And this CSF zone is increased in myopes, genital syndromes, and victimized eyes, and decrease in the hypermetropes and small pupil. If pupil is not dilated, then your central safe zone is reduced. Then central safe zone, and peripheral to this, there is a peripheral unsafe zone, where maneuvers are not very safe due to curvature of cornea, capsular fornices, and the angle region have narrow spaces. This is showing with this colored one. Then what is followability? The tendency of the nuclear fragments or cortical matter to come into the tip. The followability area is created between orifice of infusion cannula and phaco tip by eddies current due to positive infusion pressure and negative aspirational pressure. The area just in front of the tip is the area of highest followability. The angle capsular fornices are the area of low followability and need mechanical dislodgement of the pieces. And areas of no followability are side port, main tunnel, area behind the infusion ports, and corneal dome. So if some pieces are engaged in these areas, then you dislodge these by the mechanical means. Then compliance is a property of using to collapse or deform under pressure is known as compliance of the tubing. Then, sir, this is the villain of the surgery. Sudden withdrawal of the fluid from the tear chamber after occlusion break is called surge. Beyond the certain limit, it may cause collapse of the chamber. Surge proportional to flow rate and vacuum, as shown in this figure. This is a normal one. Here, occlusion is there, and there is occlusion and increase the pressure, and suddenly then occlusion is removed. Then all this liquid go in the tube, and there is a surge, and this is the main cause of the complication during the phacoemulsification. Then surge control may occur due to the certain maneuvers, like in machines there is venting. The machine has a sensor which detects occlusion break and releases fluid air into the system to fill the volume of the re-expanding tubing. Delay in start of the motor following occlusion break, and differential flow rate and vacuum settings before and after occlusion. And surgeon can do decreasing the effective flow rate, increasing the infusion, proper wound construction, increase viscosity of the AC contents, partial occlusion of the tip, and better fluid control. Then wound construction. Wound construction is very important part of the phacoemulsification. What is the ideal wound? It may be smallest, farthest from the center of the cornea. There may be no gap, and self-sealing suture is not required, and least astigmatism or no astigmatism. Then incision in phaco. There may be three types of incision usually used in the phaco. One is the scleral one, and limbal one, and clear corneal. Should be astigmatically still be present in the neutral funnel, and these incisions are formed by a sharp instrument with sharp cut, and there may be no laceration at the margin, and incisions may be biplanar or triplanar in nature. Then these are the merits and demerits of the various types of incision, like scleral incision. There is disturbance of the conductiva, but it is not in the limbal and clear corneal incision. Bleeding is more common in scleral one, minimum in limbal one, and in clear corneal there is no bleeding. Astigmatic error is least in the scleral one. Cautery is required in scleral one, and not required in the clear corneal. Anesthesia topical may be possible in the clear cornea, but scleral and limbal requires the local anesthesia, and patient is more comfortable with the clear corneal one. Red reflex is more better in the clear corneal one, but corneal burn is more, chances of corneal burn is more in the clear corneal incision. Pooling of fluid is not present nearly in the corneal one, but it may occur in the scleral and limbal one, and easy to conversion. Scleral one is very easy to convert in other type of incision, and more chances of endophthalmitis in a clear corneal type incision. So this is the merit and demerits of various types of incision. Now come to the clear corneal incision, which is most commonly used during the modern type of surgeries. It may be made by sharp instrument, and a tense eyeball are the prerequisite for good incision. Temporal clear corneal incision should be preferred. Tunnel should be square in shape, like in this. and self-threading in nature, and maybe biplanar or triplanar in nature, and make with a sharp keratome. And side port is maybe uniplanar 2 to 3 clock hour away from the main incision, and make it a 15-degree angle super blade. So important thing is that the incision side should be equivocal, and there may be cutting incision but not the lacerated incision. Then come to continuous curvilinear capsulorhexis. It is important part and removal of the anterior part of the capsule. And CC is the gold standard for the phacoemulsification. And how you form it. The first important step is globe should be in a horizontal plane and centrally placed. Keep tip of capsulotomy needle in center and give a cut radially. The length of cut is to third length of the proposed radii of the rhexis. Elevate the flap, flat it, move it with the shearing force, and try to hold flap at base and continuously change holding the side. And use capsulorhexis forceps in cases of hypermature cataract. As shown in this figure, this is the first elevated flap, first radial incision, then raise the flap and flat it, and then apply the force like it is in this direction, not in outer one or not extremely inner one. And same time, you maintain the pressure but with the help of the visco. It is very important. Then hydro procedure, aim of hydro procedure is separate cortex from capsule, minimize volume of hardcore nucleus, which requires phaco energy, separate epinucleus to make a cushion during phaco, and prerequisite to remove epinucleus easily. Hydrodissection, this is two types. One is hydrodissection. Then take hydrocannula and check it with free flow, wash almost half visco from the acid. This is very important point. Remove some amount of visco before you go for the hydrodissection. Insert tip of cannula beneath capsulorhexis margin, 2 to 3 mm inside, orifice faces towards the equator, and gently push the fluid. Fluid wave is visualized and nucleus try to bulge. Same time, stroke lens in the center. If lens moving freely or fluid wave pass from one end to other, means you have completed the procedure. Otherwise, repeat procedure with other side. Then hydrodelineation. Here you reduce the size of hard nucleus and separate it with the epinucleus. Pierce the tip of cannula in soft part of the lens and reach up to hard core. Push fluid and observe golden ring. And precaution, must rotate nucleus before starting the phaco. So rotation of the nucleus is very important step before you go for the phaco procedure. Then phaco technique, there are various types of phaco techniques. Like first one is divide and conquer, either plus sign type or V type, and stop and chop. And stop and chop may be two types. Stop and chop, and third one is chop one, which is central one and peripheral chop. First come to divide and conquer type. Here you make a two vertical, two perpendicular trenchings. These are one trench, this one is another trench perpendicular to each other. And here important point is because the nucleus is thicker in the center, so the direction, so the shape of your trench is like this, like both like, or it is a curve. It is more in the center, and nearly 90% of the depth of thickness of the lens, and it may be even in the side, and its border may be vertical. So you have a sharp, deep trench. If you are reach up to the 90%, then you go for the to break the nucleus.
A new phaco surgeon.
Then stop and chop method. Here you first make a trench and then break the nucleus and go for the chop method. Then
and I'm using sufficient amount of energy, which is
third is
adequate for this density of the nucleus,
chop.
that the tip moves in very easily without it pushing the nucleus. In fact, you can see that the nucleus material
Sound is coming from
tip as a tip is moving forward during scalp.
Then central chop.
Stabilizing the nucleus and using
adequate power during sculpting would cause less stress on the zonules and also on the PC. Secondly, we can see that the
Some
superficial
sound is coming from outer side.
so that there's no hindrance for the tip and sleeve
Then simple chop.
dense nucleus.
Here we use a chopper
Where you trench a
and
deeper
first go in the substances of the nucleus and then
very
use the
important
Phaco power and embedded the tip of Phaco inside the nucleus and then raise the vacuum. So vacuum filling is there and then apply a chopper in front of the Phaco tip and then
so it's important that we
move those pieces towards apart to each other and in this way they break the nucleus. This is the chop, central chop, and peripheral chop.
surgery.
We apply the same thing, but here the chopper is used from periphery. So first go beneath the capsulorhexis margin along the contour of the nucleus, and from periphery, our chopper is moving from periphery towards the center side and break the nucleus. And in this way, do the multiple chops, and then ultimately aspirate each and every step the pieces by the aspiration and irrigation
As
method.
deep as possible, then it's very easy to
Then
laterally separate.
nucleus removal. It is a required good hydro procedure. If good hydro procedure is there, that means the epinucleus is fully separated from the capsule. The recommended settings are low power and flow rate is near the 60 and vacuum and low vacuum. And hold roughest margin, rotate and if not well separate, then rotate and dial the this epinucleus and first try to dislodge from the capsule. When a part pulled one side, then try to introduce second instrument or may push some disco beneath the epinucleus. So ultimately it is separated and dislodged from the side and then pull it in the low vacuum settings with low power. Then cortical was removal. Remove easiest and loosest cortex first. First, do not do not remove cortex which are present in odd size. So remove easiest and loosest cortex first. Hold and try to dislodge bigger chunk before aspiration. Use second instrument to keep open aspiration pore. Use visco if AC is flat and if PC radiated with PC in center, rub it to dislodge and use both hands. For right side you use left hand and for left side you use right hand. If required, make one more side pore if it is not possible to remove with the previous pores. Then IOL implantation, load IOL under proper light and magnification. Parts of lens should not be pinched in the wrist. This is important, otherwise lens will be cut. Ensure free movement of lens in injector. Bag should be fully inflated with visco. Globe sterilized with dialer or forceps with other hand. And implant leading haptic in the bag. Push another haptic by pushing in center or slight rotation. And if iris is irregular, constrict with with pilocal before closure of the wound. Then disco removal and closing at irrigation aspiration mode. May use first and second side pores and stroke lens in the center to remove the sub-IOL disco. Then close the incision with the hydration and certain important tips and tricks for the beginners. One, that patient lying straight and in supine position. This is very important. So patient should be in a comfortable manner, in supine manner, and eyes are looking on the superior side, on the light side. Neck is in slight extended position. Eyes should be in horizontal plane in central direction, looking at the source of light. Surgeon should be sitting in superior-temporal side or for temporal clear corneal phaco. While it is speculum, exert lesser pressure, so use it. First, put some betadine wall, wash it, then visco over cornea to remove mucus debris for better visualization of the globe. First, make side port with 15-degree angle super blade at 2 to 3 clock hours away from your proposed tunnel. Then inflate the AC with intracameral anesthesia or viscoelastic resonances. If dye is required, then use the dye. Make main tunnel with keratome or microkeratome slightly inside the limbus. Tunnel should be adequate in size. just pass keratome up to the shoulder. Again inflate AC and go for the capsulorhexis. During capsulorhexis, try to keep flap lying on flat, hold near to the base, and continuously change the holding position and maintain the disco in the anterior chamber. Before hydro procedure, must remove some amount of disco. After hydro procedure, must ensure rotation of the nucleus. Enter the phaco probe with support of second instrument and in infusion on position. Use chopper over dialer in second hand for trenching movement of tip of phaco in concave manner. Lens is more thick in the center. Use phaco power to cut and not push to cut. Right? So use phaco power to cutting the nucleus, not cutting, which is most common mistakes performed by the beginners. Trench sides should be vertical. Width should be nearly 1.5 width of the phaco tip, so it not anchored in the trench. Bevel should be up and infusion port should be inside or perpendicular to the bevel, not anterior or posterior direction. Use disco time to time to inflate AC. During breaking, keep instrument deep in the trench. During aspiration, first remove easiest and smallest pieces. During cortical wash, to keep internal intact, may use other side port. During IOL implantation, AC should be fully inflated, bag filled with disco. Try to implant leading haptic in the bag. During closing of wound, some fluid pushed from outside after hydration. So your AC is properly formed. If iris is floppy, constricted with pilocarpine before closing the wound, otherwise it may be stuck in the wound. Thank you very much for my presentation. Thank you.
Thank you, Dr. Pal, for that excellent overview of the basics of phacoemulsification. You covered every aspect so beautifully and gave these final tips. I think it was wonderful. So I know it's a very vast topic to explore, but nonetheless, I would still request the panelists to come forward with their perspectives and their comments on this talk. So we'll start with Dr. Anand Bhandari, sir.
Excellent presentation, sir. A huge topic, as ma'am said. The only tips for beginners is start off SICS with the Rexis. The Rexis is the most important thing in phaco. And before that, only hand-eye coordination can be done in wet labs before they come into the OT, first year PGs. So, and you know all these fruits, the grapes and all these things they use. One more tip I would like to give is for the postgraduate, the first timers who want to, when you're scrubbing, you just think over what all you're going to do. A fast forward of what good steps you want to do and just rehearse it in the mind so that the mind doesn't go inside the word and use what to chop or what to divide, or you have a picture what you want to do and complete the case mind before when you're scrubbing, so that when you come the brain thinks that you're doing the second case. So that is how I tell my PGs to do that. And this capsular exercise, if students are doing with needle, I would always recommend them to bend themselves, because it is in the whims and fancies of your assistant. And that is the most important step for your Rexis management. So I've seen senior teachers also bend their own needle according to how they want it to be. If you're using forceps, no problem. And microscope has to be adjusted when and where necessary. It is not like you're a little lazy not to see the depth. For the beginners, it is always the depth perception is more important, where you're chopping, where you're doing the trench and all these things. So microscope position and making fine adjustments is the most important thing in these phaco cases. That's all from my side.
Thank you, sir. Dr. Meeta Joshi, would you like to add something to that?
Yeah, wonderful presentation, exhaustive coverage of all the aspects. One thing I'd like to add is using the left hand, because most of the times it is very difficult. While we are doing SICS, we don't use that left hand much. And when you shift to phaco, then you have to have quite good control over the left hand. So practice writing with your left hand. Write down the alphabet every day, and that gives you a good control over the left hand. And secondly, as Dr. Bhandari sir said, focusing the microscope. So I would add that, as sir said, use your 2 hands and 1 foot, but you have to use 2 hands and 2 feet as well, so that your microscope adjustment is also not just a one-time adjustment at the start of surgery, but a continuous process during the whole surgery. And one more thing is, when you do the Phaco, when your foot position 1, 2, and 3 while trenching, when you go forward, you be in position 3, and when you come back, you have to be in position 2, so that you don't use excess energy during the trenching process. And always keep a watch on the effective Phaco time while you are doing a case. Once you exceed a certain limit, say 2 minutes, just convert at whatever stage you are, so that the corneal endothelium does not get damaged in the long term.
Thank you. Dr. Ragini ma'am, looking forward to your comments. You've been training so many budding phaco surgeons. So what are your tips for them? Dr. Ragini? Oh, she's not there. So Dr. Pranav Ranjan, sir?
Yeah,
What would be
that
your-
was a very elaborate and very, very nice presentation, step by step, explaining all the gritty small things. What I would like to suggest to the postgraduates and the newcomers in Phaco is that the selection case is very, very important. Number one, they should not select either a very soft or a very hard cataract. 2+, 3+ grade, that should be the kind of cataract they should select. They should also ensure that the axial length, they do not select very myopic cases or very hypermetropic cases. So anything axial length between 23, 24, that is the ideal one to initiate the surgery. And third, topical anesthesia they can do it later on. Peribulbar is ideally the best to start off with, and every step should be taken into account. Like the incision should be a triplanar incision, then the use of viscoelastics should be adequate. The rexis also, they should initially make a nick with the cystitome and then use a utata forceps, because that gives more control. The hydrodissection and delineation process, that is also very, very important, because if the nucleus is not mobile and you start doing Phaco, that will lead to complications. So the mobility of the nucleus with hydrodissection or hydrodelineation is important. And then start with the technique. The nuclear disassembly technique should be 4-quadrant initially, and subsequently they can graduate on to stop and chop. Stop and chop is a very, very universal kind of a system which works with soft, hard, and every kind of cataract. So these are the tips that one should keep in mind when one is graduating initially in the initial stages of their learning.
Thank you, sir. Dr. Mohit, what would be your perspectives on this topic?
Thank you, ma'am. First of all, congratulations to sir for such an elaborate presentation, and we are thankful. For postgraduates, I was just recalling my tenure of learning. So, what difficulties I faced, I must emphasize here again that, as pointed out earlier, also, usually the postgraduates they get a chance of doing surgery maybe later on. By that time, pupils go down. By that time, not the neat cases they get. So, that adds to the challenges they face during surgery. And so, there are compromised cases. So I would recommend them to be doing on good instruments, the best phaco machine of the institute, because if the machine is giving surge, if the blades are not good, if the assistant is not good, that adds to their agony and the confidence goes down and the learning curve further increases. So they should be given neater cases first. Second, I think the trainer should make the incisions and the rexes and then make them do the subsequent steps, because these two are the pillars of the surgery. If something happens, then plan B can be opted. If the rexis goes away, the case is then given to the senior and the boy loses the chance to complete the case. So my learning was a retrograde learning, and I really appreciate the way I was taught. I was given half of the nucleus in the bag to be dealt with, and the rest was done by my teacher. So I learned how to emulsify half of the nucleus. So not the initial nucleotomy I did, not the rexus I made, not the, and the last step which I got to operate was making capsulorhexis. I used to do capsulorhexis for SICS, but not for Phaco. For Phaco training, my teacher used to do capsulorhexis so that if I falter, that can be managed. So retrograde learning is the best, giving a feel of the hand-eye coordination. I think students should be allowed to remove the visco first after putting the IOL, so they can play inside the AC and they know how much do they need to press, what is the flow, how it feels to move the instruments inside the eye. So such kind of activities can be resorted, and that makes learning easier.
Excellent pointers, Dr. Mohit.
Thank you.
Yeah, Dr. Ragini, is she there? No. Another thing that I would like to contribute to this is that I would request all the PGs to record all their cases, so they can always go back and see where exactly they went wrong. So that is very important, and that's what I tell all my PGs. They can always go back and see what happened, where the mistakes they made.
Weekly or monthly audit, surgical audit.
Yes. So with that, I think with any other pointers that you would like to add, any of the panelists? Otherwise, we'll move on to the third talk for the session. So I'll just share my screen. So our third speaker for this morning is Dr. Reshma Mehta, who is working at the Ashwini Rural Medical College and Research Center at Solapur. So to give you a brief overview of Dr. Mehta, she was a gold medalist in her post-graduation from Pune University in 1999. She went on to do a fellowship in pediatric ophthalmology and strabismus in 2007, and she specialized in ROP screening and treatment. She has screened more than 20,000 babies and prevented blindness in 200 babies, and she is very adept at laser procedures and intravitreal injections, which she has done for over to 150 babies. She has been a part of instructional courses in pediatric ophthalmology, has been very actively presenting lectures and papers in the state and national conferences, and her subjects of interest are strabismus and ROP. She won the prestigious GuruSangam Award in Delhi by AIOS last year in 2024. And she's also won other awards like the award for the best image at the MOSCON in 2022. So with this experience in pediatric ophthalmology and doing pediatric cataract, she'll be speaking to us today on pediatric cataract management. So over to you, Dr. Reshma. I'm looking forward to your talk. I request you to share your screen.
Good morning, everyone.
Good morning. Yeah.
I thank Dr. Santosh Hunawar and GuruSangam team to give me an opportunity to present in this magnificent TOT initiative of AIOS. Are my slides visible? Dr. Tinku?
They're visible.
Okay. So what is a pediatric cataract? It is any light scattering opacity of the crystalline lens is known as the cataract. It can be unilateral or bilateral. It differs in the location and severity, and it can be present since birth or can be acquired during childhood. Coming to the epidemiology of pediatric cataract, it is one of the leading causes of pediatric blindness. More than 200,000 children are blind from cataract and related causes. Congenital cataracts amount to more than 20% of childhood blindness worldwide. We actually see more than 3 or 4 cataracts per 10,000 live births. Prevalence of unilateral and bilateral cataract is same worldwide. So coming to the development of lens nucleus, initially we have to see look at the development of the lens, and this is any disturbance in the embryonic nucleus which develops from 0 to 3 months intrauterine will lead to the congenital cataract. and fetal nucleus which develops from 3 months of gestation to birth. So any disturbance during this period of growth of the lens will lead to formation of an opacity, which is known as the congenital cataract. Another thing that is the infantile nucleus, which is blue in color, it develops from birth to puberty, and adult nucleus which develops from puberty onwards till 20 years of age. So any disturbance during development of this nucleus, that is the infantile nucleus or the adult nucleus, there will be an opacity, formation of an opacity and a cataract, which is known as the developmental cataract. And the beauty of this cataract is that the rest of the lens will be clear. This is a patient of congenital cataract who presented in the OPD with a white spot in the eye. So coming to the etiology, 33% of total cataracts are the cause is not known. In spite of a good family history or a good detailed examination, we will not find the cause. So others are hereditary, maternal factors and fetal factors. So in hereditary, we have chromosomal disorder trisomy 21, the Stickler syndrome, Loeys syndrome and Down syndrome. The maternal factors, we have to ask good history during the ANC period during pregnancy. So whether there is malnutrition, there is infection because of torch, you ask for history of fever with rashes, we ask for history of drugs, steroid intake, or whether there is any exposure to radiation. These factors are very important to know the cause of cataract. And most of the times when we operate the cataract, we should know the ANC history to also know the clinical status or the systemic evaluation of the baby, to know how the child is going to proceed or progress. The fetal factors like oxygen deficiency, birth trauma, any metabolic disorder like galactokinase deficiency, galactosemia, malnutrition, and congenital other disorders. So oxygen deficiency is very important. The birth history, whether it was prolonged labor or there was immediate oxygen support in the PNC period, or there is a delayed cry, which leads to hypoxic ischemic encephalopathy. This history has to be elicited to know the prognosis of the child. Most of the times, the parents are very apprehensive when we take the patient for surgery. And then they will ask, after surgery, will my child be able to see? And after the surgical outcome, whether the surgical outcome will be good, visual outcome will be good, but whether my child will be able to walk, whether the child will be able to run, whether the child have normal milestones. So all these answers will be, you will be able to answer them if we have taken a good history of the maternal factors, that is during ANC, and the fetal factors, that is the birth history during delivery and just after delivery, how his stay was in the NICU or in the perinatal period. So this history is very important. Then coming to the types of cataract, we have the capsular type, that is the anterior capsular cataract and the posterior capsular cataract. Then we have the polar cataract, that is the anterior polar cataract and the posterior polar cataract. We have the congenital cataract, nuclear cataract, cataracta pulverulenta, lamellar cataract, total nuclear cataract, sutural and axial cataract, the generalized cataract, coronary cataract, blue dot cataract, total, and the membranous cataract. The membranous cataract is absorption of the cataract and appears as a thin membrane. Sorry. So the posterior cataracts are more visually significant, and usually posterior polar cataract or posterior subcapsular cataract are because of use of steroids or could be because of the blunt trauma. So here we have a picture which talks about the morphology of the cataract. I'm extremely sorry for this repeated thing. So actually the etiology Yeah, so this is the picture which describes the total cataract, the nuclear cataract, the polar cataracts, the lamellar cataract, the cortical cataract, and the blue dot cataract, and the sutural, bisutural cataracts. So we now shall see the most common types of cataract, which is the lamellar cataract or the zonular cataract. It is in one zone and hence the name. It is in one lamella of the lens and hence the name. The cataract which occurs in a specific zone, the linear opacities are like the spokes of the wheel. The posterior polar cataract, opacities are seen at the posterior pole of the nucleus and the appearance is like the onion whorls. It is associated with Mittendorf's dots, which is a remnant of persistent hyaloid vessels. Then we have the punctate cataract. Opacities are stationary. There is no loss of vision. Can be associated with Down syndrome. You can see that they are just very tiny, small opacities, and hence we need not operate on such patients who have punctate cataracts. Then we have the coralliform cataract. Even this can be sparse and not visually, and we will not have loss of vision. So we can leave these patients alone and see to it how they are progressing. Then we have the rubella cataract, which is very commonly seen. Rubella cataract is associated with microcephaly, persistent ductus arteriosus, and the cataract. And the triad it has is the salt pepper retinopathy. Is seen in the retina. In the peripheral retina, you will see the black tiny spots. That is the salt pepper retinopathy. The patient will have glaucoma and there will be a nuclear cataract. So we have to be very careful while operating patients with rubella cataract. It can be also associated with microcornea, microphthalmus. Next is, now that we have seen that this baby is having okay, so there are other types of cataracts. That is the sunflower cataract, which is seen in Wilson's disease. Then we have the Christmas tree cataract, the oil droplet cataract, which is seen in galactosemia and other metabolic disorders. The persistent fetal vasculature, which can be associated with anterior cataract and a dense posterior cataract also. And the vessels will be very much we have to, when we are operating on such a patient, we need to also have a cautery in place and pars plana lensectomy, vitrectomy backup with us to cut the stalk, which will bleed. So depending upon the morphology of the cataract, we have to plan the surgery and we have to plan for the entire visual outcome, a good visual outcome. So what will happen to this child who develops cataract at the age of 1 month or 2 months? That is the congenital cataract. The child's cortical visual pathways does not develop as there is no visual stimulus to the brain. This results in decreased visual acuity. The first 2 months are critical for visual development, and visual development continues until 7 years of age. Amblyopia is more common in unilateral cases. The first 2 months are very critical for development of vision. Development of amblyopia is more common in unilateral cases of cataract. So we have to rule out amblyopia because of cataract, and we have to treat cataract early so that the patient does not become amblyopic. So now coming to the diagnosis of pediatric cataract, is the child presented in the OPD for poor vision? If the child is less than 2 years, the informant parents will tell us that there was a white spot or there is a white spot in the eye. The baby does not look at the mother's face, does not follow objects close to face, and the baby does not smile while looking at the mother, or there is a blank look. So this is the history which is given to us. If the child is in the school-going age, the parents will bring the child saying that the child cannot read the blackboard clearly, there is difficulty in viewing distant objects, and the child may have esotropia or exotropia. And if the cataract is very dense and since birth, the patient may also present with nystagmus. So what is the first thing that we do is we dilate. The patient is subjected for pupillary dilatation. We do a retinoscopy, and in the retinoscopy or the distant direct ophthalmoscope, we look for the red reflex. This is also known as the Bruckner's test. It indicates that there is a media opacity. If there is a media opacity, then on careful examination, we will see that there is a gray reflex and not a red reflex. So normally, we should be able to see the red reflex in both the eyes in the patient. But here we are seeing a gray reflex, and this gray reflex is because of the media opacity. So we have to find out this media opacity is because of the corneal opacity or congenital hereditary endothelial dystrophy or anything in the vitreous like persistent fetal vasculature or cataract. So when we know that the cornea is clear, the vitreous is clear, then it is only because of the cataract. We can see it also on the slit lamp and on the under the microscope. You also look for the, so here you can see the opacities, the triangular opacities on the red reflex. You can see a gray white opacity, and in the right eye we can see a bright red reflex, but in the left eye we see a white reflex. Similarly, here also we can see a dense white reflex in the left eye and a red reflex in the right eye. So we also should know what are the other causes of leukocoria, that is bilateral corneal opacities, bilateral sclerocorneas, or SHED, that is congenital hereditary endothelial dystrophy, buephthalmus, retinoblastoma, then Coats disease, stage 5 ROP, or a dense coloboma, choroidal coloboma. So we should rule out all these causes and only then take up the patient for surgery or counsel the patient for surgery by first ruling out all these causes. So diagnosis of pediatric cataract. First and foremost is the red reflex. Red reflex should be seen at every visit, and each eye of the child should be seen for the red reflex at every visit. If it is a small opacity, we ask the patient to follow up for 3 months, 6 months. But every visit you see whether that lens is clear or the opacity is progressing or it is becoming more dense. And vision screening should be done from 3 years onwards. And if there is any poor vision, you should refer the patient to the base hospital. Family history, to ask if the parents or grandparents or aunt was is suffering from cataract related problems or nystagmus or squint. So it will tell you if it is a hereditary cataract or anything related to the genetic cause of cataract, whether it is autosomal dominant or recessive. Then slit lamp examination, thorough slit lamp examination is done to know the morphology of the cataract, whether it is in the anterior capsular area or the posterior capsular area or the anterior polar or posterior polar, and what is the location and severity. So if the lens opacity is 3 millimeters in size, then we wait and see for the progression of the cataract. If it is between 3 to 5, the opacity is between 3 to 5, we still wait and see for the progression of the cataract. If it is more than 5 millimeters of opacity, then we need to operate such patients. If the cataract is in the anterior, if the cataract is in the anterior capsular area or the anterior polar area, then we can wait and see the vision. If the vision is less than 618, then we have to operate. If the vision is 618 or better with accommodation, it is good. It is best to leave the patient alone rather than have 6/6 vision without accommodation. So always, if the vision is very poor, then only we operate. Otherwise, if the vision is 618 or above, we can leave the patient alone because it is his accommodation is still working. If the cataract is in the periphery and small, then we can wait. But if there is large astigmatism and wrinkling of the posterior capsule, then we have to operate. So what are the indications of surgery? It depends upon the size of the cataract, that is 3 to 5 millimeters. Anything more than 5 millimeters, you need to operate. whether it is anterior or posterior. Anteriors can wait. Posteriors, because it is near the nodal point, we have to operate early. And just a minute. So indications are, if the patient is having total cataract, if the patient is having squint, if the patient is having nystagmus, we need to operate such patients. We should not wait, because then there will be more amblyopia. If the patient is having resistance to occlusion, there is right eye is having pediatric cataract and the left eye is good. So we are occluding the left eye, but you can see in the picture that the child is not allowing us to occlude the left eye and he is crying. So it is resistance to occlusion. So we need to operate such children. So obstruction of the central lens, which is 3 to 5 millimeters red reflex on ophthalmoscopy, we should operate if it is the red reflex is poor and if the opacity is more than 5 millimeters. So workup of bilateral pediatric cataract, as we have already discussed the family history. If there is anybody in the family who was operated in childhood for cataract, if anybody in the family who is with strabismus or with nystagmus, we should evaluate to know what is the cause of strabismus and nystagmus, whether there is a cataract which was unoperated. Then in the family history, whether there is history of any syndrome, and to see whether the systemic or any metabolic disease in the child. So galactosemia, galactokinase, Wilson's disease should be tested. Then history is important again, as we've already discussed for the torch titer in ANC period, whether the mother had fever with rashes. That is, it will lead to CMV retinitis or CMV meningitis, which is very common. And CMV hepatosplenomegaly, there will be a yellowish discoloration of the cataract, yellow sclera, in patients with torch titer positive. These patients we will operate, but they have high chance of having post-operative inflammation. And when subjected to general anesthesia, we may risk the life of the baby because of poor deranged liver functions in such patients. Hence, systemic evaluation is very important in such patients. Reversible cataract. Galactosemia is also known as reversible cataract. This baby was brought to us with white opacity in both the eyes, and he had white cataract in both the eyes with fatty liver and galactokinase deficiency, failure to thrive. So such patients, why do we call it as reversible cataract? Because once we give them diet control or galactose-free diet, the cataract may reverse. And we may feel that why did we operate on such patients, even if it is a white cataract. So we should know the cause of cataract before we take up the patient for surgery. Also, it is known as the oil droplet cataract on indirect ophthalmoscopy. Another thing, if we have taken a good family history, we have examined properly, we've done all the blood investigations. But if you see the extremities, you will see carpopedal spasm. This is seen in hypoparathyroidism. And when we take up such patients for surgery, we may also risk the life of baby because of tetany. So again, we should see the baby completely and then only post the baby for surgery under general anesthesia. Another limb anomaly seen is the thrombocytopenia with absent radii. This is a syndrome, and when we post such babies for cataract surgery, we may risk the life due to intractable hemorrhage. Hence, we have to be very vigilant before taking up the patient for surgery to rule out all systemic anomalies, to check all the systems properly, and to have a thorough blood investigation and to have a thorough workup. So again, history is important. Birth history, antenatal history, family history, systemic evaluation is very important to look at all the systems, right from history of convulsions to history of upper respiratory tract infections or any loose tooth is very important, as we are subjecting the patient for surgery under general anesthesia. Again, we have to rule out any septic focus such as boils, blepharitis, conjunctivitis, or any lacrimal sac disorders. Only when we get a green signal from all the systems and that there is no septic focus and all the systems are good, the family history is okay, the blood investigations are good, the liver function test, kidney function test, then we go ahead for surgery. And it is a team approach. It is a team approach. The pediatrician, anesthesiologist, ophthalmologist, optometrist, parents, and the counselors, everybody is involved and everybody should work together to have a good visual outcome. Now, when and whom to operate? Again, we are stressing on, because we will see this lamellar cataract. So if the cataract is not very dense, we can wait. We should ask the patient to come for follow-up frequently. It depends upon where is the cataract. If it is in the center, then we need to operate. If it is in the periphery, we can wait. And depending upon the refraction, we have to decide. These pictures show that the cataract is dense in the periphery and it is progressing to become a total cataract over the years. So such cataracts, then we need to operate. Cycloplegic refraction is very important before we take up the patient for surgery. Spherophakia and congenital cataract present with myopia and high myopia. Subluxation of lens present with high hypermetropia because the lens is shifted away from the pupillary area and the child may be aphakic. Hence, cycloplegic refraction is very important before we subject the patient for surgery. So now when we've decided that we are going to operate these patients, this is the pyramidal cataract, which shows that it is in the posterior pole and hence needs surgery as it is more than 5 millimeters. And this is the slide which I was trying to search previously, and sorry for the same. So this slide which shows the anterior polar cataract above and the posterior polar cataract below. So the posterior polar cataract is at the nodal point, and the schematic presentation shows that when the cataract is at the nodal point, the ray of light which is bisecting at the nodal point will not have a clear image on the retina, and the image will be blurred, which will further lead to amblyopia. And hence, we need to operate these posterior polar or posterior pyramidal cataracts, even if they are small in size, as they hamper the retinal image. And the anteriors can wait. Similar picture which shows the side view and the retroillumination of the anterior polar and the posterior polar. I have an interesting case to discuss over here. You can see the right eye, the biometry, the lens thickness is 3.55, and in the left eye, the lens thickness is 4.46. It is encircled in the red mark, and the keratometry readings also in the left eye can be seen with the significant cylinder. So actually the patient presented with us saying that the parent had brought the 9-year-old child who could not see the board clearly. The teacher was unhappy with the child with his studies, and the child could not see well with his left eye, had exotropia, and we took his history. He was a preterm ROP baby, but doing well. So we saw his fundus. Fundus was good. It was a normal fundus, but then when we had dilated and then taken the retinoscopy and the red reflex was clear in his right eye, but the red reflex was not clear in his left eye and had an opacity in the center, a dense black opacity in the periphery. So then we did his slit lamp examination and we could see one small white opacity in the periphery of his lens in the posterior aspect. Then we posted the patient for biometry and we could see that the lens is swollen and it is bulging and it is bigger than the right eye. But I thought his refraction, when we immediately first saw the refraction of the patient, he was right eye minus 0.5 and minus 0.5 at 20 degrees, and left eye was minus 8 and minus 2.5 at 150 degrees. So initially, when we saw the refraction, I thought it is a case of unilateral high myopia. But on doing biometry and doing slit lamp examination and doing the red reflex test or the Bruckner's test, I was wrong. It was not a case of unilateral myopia, but it was a case of unilateral cataract with the same axial lens in both eyes, 22 millimeters, 22 millimeters. The lens is swollen in the left eye. And because of the capsular wrinkling or the thick posterior capsule, there was a high myopia or the high refractive error. So it was a very interesting case, and we had to take a specific angle. Only then, when the patient was looking up, only then we could see that white opacity to capture it on the camera. Otherwise, we were not able to see the white opacity. So this was a case which we would have missed and put it as unilateral myopia. But because we did the red reflex Bruckner's test, where we could see the media opacity, on the biometry we could see a thick band behind the lens or behind the posterior capsule, and definitely the lens is swollen, which is 4.55 millimeters, which is seen on the biometry. So this was a very interesting case and has done well. So before taking the patient for surgery, what else do? Is we do a B scan and we do a A scan. So before the B scan and A scan, we have this slide of non-surgical treatment. So in non-surgical treatment, if the opacity is less than 3 millimeters, we observe, we ask the patient to come for follow-up, and we do the red reflex test every follow-up and see whether the red reflex is good in both the eyes at each visit. So the surgical treatment of pediatric cataract is if the opacity, central lenticular opacity, is more than 5 millimeters, more than 5 millimeters, you take the patient for operation. If it is more dense, you take the patient for operation. If it is large, you take the patient for surgery. If the refractive error is more, as we have just seen in one of the cases, you take the patient for surgery. If it is unilateral, we operate earlier, as early as 6 weeks. If it is bilateral, we can wait and we operate at 8 weeks, within 1 to 2 weeks for the second eye. And after bilateral surgery, we need to rehabilitate the child by giving intraocular lenses or Phaco glasses or contact lenses. Unilateral cases, there is high chance of amblyopia. So when we are doing the A scan, now as soon as we know that there is a cataract, first and foremost is we say that we have to implant a lens. But we have to be very cautious, depending upon what is the age of the child, what is the axial length of the child, and what are the corneal curvatures. Depending on that, only then we will decide whether we are going to implant the lens and which lens we will implant. So there should not be any misestimation of the IOL power. So corneal curvatures, the preterm infant has a very steep cornea of almost 50.75 diopters. The full-term baby will have 48.5 diopters. And by 6 months, it starts becoming flat to 49. And in 1 year, rapidly, it is almost like an adult, 44 diopters, the corneal curvature. And by 2 years, it is 43 diopters. So the corneal curvatures are as high as 50 to 48 in the preterm and full term. So we have to be very careful before we are estimating the IOL power. Again, the axial length in the preterm and the full-term babies, it is 14 to 16 millimeters. And by 6 months, it is 18. And by 1 year, it is 21. It has almost reached the adult by 1 year. So there is fast progression. And by 2 years, it can become 23.6. So IATS studies and most of the senior ophthalmologists wait till 2 years to implant a lens. And why? Because the corneal curvatures, the cornea is going to become flat from steep, and the axial length is going to grow to the normal adult size. So to avoid misestimation of the refractive error and miscalculation, we have to wait till 2 years of age before we implant a lens. Though you feel that during surgery is very easy, it is just irrigation and aspiration. But these adorable angels do require good vision and good visual outcome after surgery. Hence, very important to have the best calculation for implanting an IOL. So which formula will you use? We have the Dahan et al. And the NAD et al. Formulas. So less than 2 years, we do 20% undercorrection for the IOL power, whatever IOL power is estimated. 2 to 8 years, we do 10% of undercorrection of the estimated IOL power. And more than 8 years, we do not undercorrect. Another formula to counter check is rule of 7. That is age plus target hyperopia is equal to 7. So according to American Academy of Ophthalmology, we have to have this residual refraction after surgery. So most of the ophthalmologists will come and say, my patients have developed so much amount of myopia. So as age advances, they are growing tall and progressive myopia is setting into it. But I feel no, we have to check the axial length always before we say that it is progressive myopia, because you have operated the patient at the age of 3 years or 4 years or maybe earlier, and maybe because of some misestimation of the IOL power or miscalculation of the IOL power, you're not getting the target refraction. And hence you feel as the age advances 8, 9, 10, the child is developing high myopia. So unless until the axial length is corroborated, I would not put it as progressive myopia. So, but we see many children who are having -8, -6 in their age, in their school-going age group, who have been operated earlier elsewhere. So this chart is very important to know that what residual refraction you have to aim for when you are operating small children at 2 years, 3 years, and 4 years. So we should be very, very calculative about it, rather than saying we have a lot of myopia children later who have been operated for cataract and with IOL. So the infant phakic treatment study is very important. This was a randomized multicentric study done over 5 years in USA, and which tells that no IOL, those children who were implanted with IOL prior to 6 months of age or less than 2 years of age had adverse effects rather than those who were not implanted in IOL. So these children had adverse effects, and like secondary open angle glaucoma, infections, inflammations, subluxation of the IOL, a dense pupillary membrane, and these patients had to undergo multiple intraocular surgeries. So according to the infant phakic treatment study, we have to follow the protocol that wait till 2 years of age to implant an IOL, though you feel tempted that it is just a very simple procedure to do INA and implant a lens. But we should still wait to just avoid the misestimation or the miscalculation of the lens that you're implanting, and not to have the child to become amblyopic. So coming to the surgical technique, one thing which my slide is not here is the B scan, which says that when you cannot see the fundus of the child, we have to do a B scan to rule out other causes of leukocoria, other causes of cataract, or in spite of a cataract, we do not have any surprise later, that is retinoblastoma or a PHPV or FEVR or Coats disease or a coloboma. So a B scan is also must before you take up the patient for surgery. So when you've taken up the patient for surgery, first and foremost is the 5 mm anterior capsulorhexis, that is mandatory, and then is the posterior capsulorhexis that you go in for. You take a nick with the cystitome, and then when you see this triangle, you start doing it with the forceps and complete the posterior capsulorhexis, which is to be 4 mm. And then we need to do the anterior vitrectomy till you see that there is no tenting of the posterior capsule anywhere. And so the anterior vitrectomy is complete. Now, this is important. A good capsulorhexis is important, and a good anterior vitrectomy is important to avoid migration of these epithelial cells on the posterior capsule or on the vitreous phase. So when you have the good anterior vitrectomy done, there is no scaffold for these epithelial cells to migrate on, and the visual axis remains clear. So the first and foremost complication to avoid is to avoid this visual axis opacification. So intraoperative, we have to be very meticulous, very gentle and patient to aspirate all these epithelial cells and do a very good anterior vitrectomy so that we have no visual axis opacification in the early post-operative period, because there is 100% incidence of posterior capsular opacification in pediatric cataract. Another thing is the anterior capsular size should be 5 to 5.5 millimeters to avoid capsular phimosis and to avoid capsular fibrosis, because if there is too much of phimosis and fibrosis, it will also decenter the IOL and the visual axis will not be clear. For when you are leaving the child aphakic, the capsular axis should be 6 millimeters. The anterior and the posterior capsular axis should be large so that it does not retract, and we can put in the IOL intraocular lens at a later stage. Secondary intraocular implantation can be done on the support of the anterior and the posterior capsule. So concluding, I would like to conclude by telling few differences and similarities between the pediatric cataract and the adult cataract. So in pediatric cataract, the cataract morphology is very important. We should be able to identify which type of cataract it is. So it will help us to give a good diagnosis, whether it is a diabetic cataract or whether it is a Christmas tree or the Wilson's cataract, sunflower cataract. So we have to identify the type of cataract. So lamellar cataracts, we need to operate. Zonular cataracts, central dense cataract, which is more than 5 millimeters in size, we have to operate. The posterior polar ones have to be operated because they are at the nodal point and the retinal image will be blurred. When we see that there is persistent fetal vasculature, we have to be vigilant about the anterior vitrectomy, about a cautery during surgery, because we may face bleeding during surgery. Then timely surgery. Timely surgery is we should 6 weeks for unilateral cataract and 8 weeks for bilateral cataract. Why we want to do a timely surgery is the first 2 months of the child's vision are very important for development of vision, and this vision will also help for the cortical visual pathway. If there is interruption of vision in the early period, it will lead to amblyopia. Hence, timing of the surgery is very important. We do not want to wait for long. Surgical method, which surgery will you prefer? So it is for bilateral cataracts, it is very important. Less than 2 years, you do lensectomy, you do capsular and anterior vitrectomy. Suturing the wound is also important. It has to be partial thickness and not infection. In unilateral cases, early surgery, and you can implant the lens if the child is about 2 years to avoid amblyopia. Then surgical inflammation. If we implant a lens before 2 years of age, please look for secondary open angle glaucoma because of the lens, and inflammation or infection and retinal detachment. So surgical complications have to be seen, and hence you have to ask the child to come for follow-up. Posterior capsular opacification is one of the main complications which is seen in almost 100% children, like incidence. There is 100% incidence of PCO. So we have to avoid that by doing a good primary posterior capsular axis and by doing a good anterior vitrectomy. The last and the most important thing is visual rehabilitation. We need to give glasses. Once we give them glasses, we need to spend more time, teach them So visual rehabilitation is more important. They will be thick glasses because they are aphakic glasses. We also get ultra thin high definition glasses, as seen in this picture. The gray glass above is the ultra thin high definition glasses. So the weight is less and the thickness is also less, so it does not rub against the eyelashes of the child and it does not hurt the child. So visual rehabilitation is very important. Though the cataract surgery, many of the cataract surgeons, robust cataract surgeons, find it very easy that they can do pediatric cataract surgeries under anesthesia very well. But I would like to insist that refracting the child every 3 months or 6 months and giving good glasses and seeing that they are wearing the glasses is very important, because we have to counsel the parents that unless or until you wear your glasses, the child will not be able to do any activities in later age. So it is very important that the child should wear glasses and his vision should be restored, not only operate and say bye-bye. So I think I have conveyed my message to all the postgraduates about the type of cataract that they're going to operate and when to operate, and also visual rehabilitation and follow-up is very, very important. Thank you.
Thank you, Dr. Reshma. That was a wonderful exposition on pediatric cataracts. You not only elaborated the morphology of the cataracts, but also the indications for surgery, the timing of surgery, tips for surgery, and also you drove home the point that how important the follow-up of these patients is. So thank you so much. That was a very detailed and a very complete presentation. So with that, we move on to our discussants for their perspectives on this talk. I'd like to start with Dr. Pranav Ranjan, sir. Sir, any points that you would like to highlight or add to this?
Very exhaustive presentation by Dr. Reshma, and she has almost covered everything. I mean, what she has already conveyed, that amblyopia management, the time of surgery, the type of IOL, the power calculation of the IOL, the post-operative complications, they have to be managed well. One thing I would just like to add is that a child who is able to sit on the slit lamp, for them, a posterior rhexis can be avoided during surgery. So any child between the age of 5 and 7, you can just do a normal surgery. And if there is a opacification in the posterior capsule, you can do a YAG laser at the age of 5 and 7. And number 2, for all pediatric surgery, suturing the incision is extremely important because they are uncooperative people. So tight sealing of the wound is extremely important. I mean, these are the few things which I would like to add upon.
Thank you, sir. Dr. Anand Bhandari, sir.
Great presentation. Everything covered in minute details and nothing more to add, but a big emphasis on the genetics and the counseling of the parents. They won't think one surgery is over and the child has got complete vision, because they don't know what to grade vision like. And counseling the parents for the next child and finding the etiology, systemic examination, complete pediatric referral examination with the blood and other investigations. Madam said everything. I'm just emphasizing on that. Early rehabilitation after surgery is the most important. Only one question to ma'am: only anterior vitrectomy, or do we do pediatric surgery, cataract surgeons do pars plana also?
No, we will be doing pars plana also.
Yes,
yes, pars plana, lensectomy, vitrectomy also.
Yes, ma'am. Yes, because I am not very needling. Everybody tries to. The only thing is how to do management after the surgery and what to etiology to find out, and other systemic disorders to find out will help in the patient's prognosis. Thank you, ma'am. Very nice.
Thank you, sir.
Dr. Meeta Joshi, would you like to add something?
Yeah, wonderful presentation, ma'am. Could you just elaborate a bit on the viscoelastics which we use during the surgery, especially during the posterior capsular rhexis?
Yes, viscoelastic, we can use the dispersive ones, and the cohesive ones we use during the anticapsular rhexis, but otherwise we can use the dispersive ones during the PCC. And we should be able to do the antivitrectomy well so that there is no tenting of the posterior capsule. Do it until you see that it is a round PCC.
Thank you.
Thank you.
Dr. Mohit, any perspectives on this?
Yeah, thank you, ma'am. It was great presentation. I just have some small query that do we always just follow the nomogram or we have something better to get the keratometry of these patients done prior to biometry?
Better thing is we post the patient for examination under anesthesia, and with the handheld keratometer, you do the keratometry, K1, K2. For the small ones, for the 2 years, 3 years ones, who cannot sit on the biometer.
Yes, yes. So
Yes, for the small
these
ones.
days, which kind of which handheld keratometer is being used? Earlier, Bosch and Lomb was giving. Now they've stopped manufacturing. So I just want to know which one is available.
Yes, so we have the handheld auto ref with K from Nidec.
They have stopped giving it, and in tsunami, their manufacturing unit got vandalized. So now
Okay.
they are
But
KLB is not
but
giving.
I still have it, sir, in my OPD, so we still use the same.
You are lucky to have it. Uh,
And it has the perfect readings.
yes.
If I compare it with any other instrument,
Correct. So
there.
if anyone else can guide me on which one to buy, because I was searching some Chinese company, they were there, but not trustworthy, no after sale service. So I think this one equipment we are lacking, that how to procure and from where to procure. That facility was in Nicobar Islands and that got vandalized. And one more thing, if there is uniocular cataract, a dense cataract with strabismus, how do you approach that? When to stage what?
So if the child is old enough, like 7 years and above, we can go in for cataract with strabismus surgery in the same sitting.
Same sitting.
And yes, but if the child is old enough, if they have come very late, but if the child is small and it is presented to you, then you first do the cataract, and then you correct the strabismus by patching, by doing exercises, orthoptic exercises for that eye, for improving the vision, and give it a chance for it to align straight.
How long? How long
For,
can we
for
wait?
so if the child is 2 years, 2 to 3 years, 4 years, till 4 years, and then if the strabismus is not improving, then you can go in for the strabismus surgery.
Okay. Thank
So
you.
anybody above 8, we would do 2 surgeries in the same sitting, but anybody very small, we would do one by one.
Okay. Thank you, ma'am. Thank you.
Yes.
Dr. Anant, you were asking about the past planar approach to
Yes,
doing
yes,
the
ma'am.
PCC. So we can do it. It's not the past planar, actually, it's through the past plicator because we go in a little nearer in children. So we can go through the past plicator and do the PCC. You can also go through the anterior route, through your corneal incision. You can go behind the IOL, and with the cutter itself, we can do the PCC as well as the anterior vitrectomy. It works very well. You don't have to do a manual PCC then. With the cutter itself, you can do the PCC. And
So keeping the lens as a stable thing.
yes.
Protected from it.
So yeah, the better approach would be to go through the past plicator. If you're conversant with that.
Thank you.
Yeah. So Dr. Reshma, in your last slide, you touched upon the multifocal IOLs in children above the age of 3 you mentioned.
Yes.
So I'd like the opinion of the panelists. Do any of you have any experience in using multifocal, and should they be used? What are the outcomes? Anyone would like to comment on that? Or Dr. Reshma, what would you say? Should they be used?
No, I have not used, and I would not actually recommend, but it is in research, and it is in many of the papers where they are trying to find out the results of multifocal because of the near ad. So chances of amblyopia, they say that would be less because most of the times the children are doing near work and they should have good near vision.
Yes.
So when we target for our refraction, or when we calculate our IOL powers, we usually aim for distance and then we give the near ad. But for multifocals, they already have the incorporated near ad. So they find it, they are still under research saying that it would be better. But it is still, we have to take it with
we
a
have
pinch of
been using in our center in Gangaram, we have been using multifocals. What I've seen is it works for a few years while, the child is studying in older children. But then down the line, they do require near correction. That's what I've seen.
Yes.
It does work for a few years. What about toric IOLs? So if a patient has a high cylinder, at what age would you recommend that a toric IOL be implanted? When the
toric IOLs, as I have given, I have shown you one of the pictures there. So if it is because of the IOL, or because of the corneal curvature, or if it is because of the lens, we have to find out the astigmatism is because of what, and only then we put in the toric. but you can put in toric for older children.
Yes, we need to have a very crisp biometry, then only we can go for it.
Okay. Yeah. So in older children, I think toric would be advisable. And Dr. Ragini, is she here? She's busy in another conference, IRSI at Amritsar. So any of the panelists, if you have any concluding remarks or comments, are the most welcome. Otherwise, we'll wind up the session. Okay. Okay. So thank you all.
A
I think,
wonderful
yes, ma'am.
session, and we covered the topics today in a very exhaustive manner. And so it's like getting back the basics right and learning the day-to-day tips which are important when you start practicing. Because theory is all fine and good for your exams and everything, but the moment you sit on the OT chair and start operating, it all goes out, and then only the practical things remain how to proceed. So very good tips today. Thank you.
Thank
Correct.
you. Thank you so much. Thank you all for your presence with us this morning.
Thank you.
It's really our pleasure to have the wonderful discussions that we've had. Thank you to all the speakers for the wonderful talks. All the talks were so complete, very well illustrated with great take-home messages. And I thank the audience that has logged in and was with us this morning. For the benefit of the audience, we'll be having another Guru Sangam session today at 6 o'clock. So I request all the PGs to log in again, and then more sessions on the weekend, that is on Saturday and next Sunday. So with that, I bid you goodbye.
This is a
Thank
bigger
you all.
Sangam than your Kumbh Mela.
Sir?
Thank you.
This is a bigger Sangam than the Mahakumbh Mela, I think. Morning, evening sessions.
Yes,
Good.
true.
You have to go all out if you are doing
It
it.
was
Otherwise, no.
extremely nice. Extremely nice for us also. Lot of information,
Yeah,
lot of
yeah.
learning for us.
Yes, sir.
So much of learning. So much of learning.
So much
Correct.
learning. Everybody's
Thank you.
pulse. Yes.
Thank
Thank
you.
you, ma'am.
Thank you so much, everyone. Thank you. Bye-bye.
Thank
Thank
you.
you,
Thank
madam,
you.
for
Goodbye. Have a
thank
great
you.
Sunday. Thank you.
You too, ma'am. Bye bye.